what makes a donor a good donor to begin with. And a lot of it is when you're working in medicine, you always want to rule out or eliminate risk. That's the big goal when you're treating patients. A lot of things that damage the gut microbiome. One classic example is alcohol. Like, we know alcohol is toxic to the microbiome and damages the microbiome. This concept of like finding one person or one thing that's going to be the fountain of youth doesn't really exist. It's lots of things. And that's really what it comes down to from a donor screening standpoint. There's not one magical microbiome out there that's going to help everybody. But are there microbiomes out there that can help a lot of people? Definitely.
Something exciting to talk about today, which I feel like both of us might be overly passionate about, is the concept of a super donor. And so a little history on where this word kind of came from for everybody that has not heard the term super donor. So in a lot of trials, specifically within inflammatory bowel disease or IBD, there were some kind of inconsistencies in treatment response. And so this was tied to the idea that some donors are better than other donors. Unfortunately, the word super donor kind of came to be from this. And so it's really an oversimplified concept on top of a very complicated process. And one of the things that I find funny when you're reading about this concept is that they define a super donor as someone who portrays health benefits to a recipient through whatever the donation is. And for us, it would be stool donations. But that's just what a donor does. And so it makes the idea that there's some magical super donor that exists that's just better than everybody else. But that's not really what's happening. And so today we're going to get into exactly what a super donor is, or why super donors aren't really just some magical unicorns kicking around. So do you want to lead us off, Jason, and kind of give us an idea for you, what you kind of would define, why this doesn't quite work?
Yeah, I mean, it really comes down to what makes a donor a good donor to begin with. And a lot of it is when you're working in medicine, you always want to rule out or eliminate risk. That's the big goal when you're treating patients. That's the approval process for any drugs. Like, are the benefits higher than the potential risks to the patient? And so in the context of a donor program and screening donors, the criteria of entry are just really, really high. And if you look at some of the published research, including our own work around our donor program, the acceptance criteria of a potential person into the donor program is really, really high. It's really hard to achieve. Like, they're being accepted into these programs somewhere between like a 3 to 5% of the people that apply. And so the types of people that meet even the entry criteria that we set, and just to give you an idea for what that is like being breastfed, being vaginally born, limited to no use of antibiotics, eating a broad omnivorous diet, not on any medications, not having any, sleep disorders or anxiety or digestive symptoms or allergies. I mean, the list really just goes on and on. And even just ask yourself, right? Are you potentially a donor for the program given those entry criteria? Or do you know any friends or family who just off the top of your head would meet those requirements? I mean, we really are, and especially in the Western world, there's an epidemic of chronic disease. And so just finding people that meet the entry requirements, in my mind, automatically makes them a super donor if they can just get through that initial screening. And then on top of that, there's a whole bunch of other screening in blood and stool and family medical history and past medical history that really even eliminates more people. So that's the general concept. And it is, mildly frustrating that this branding around super donors has come to be, because people think that, there's something out there, as you pointed out, that's this sort of unicorn that's going to improve everybody's health. But it's much more complicated than that, because one donor that might really work for one person isn't necessarily going to be the same donor that works for another person. And so I think it's more about the potential of matching donors to each other, and that's something that we're not currently at yet as far as the available data and research, but it's something to be aspired to for the future.
Yeah, and then I think that's where it comes from on donor screening. everyone that's healthy, everyone that's an elite athlete, everyone that's elite in their healthcare, they're not automatically going to be a good donor, because part of this screening that we're doing and that's done in anybody that's, you know, creating high quality products, what we're looking for is not just what someone's aware of, but also things that they might be carrying that aren't affecting their health, but could be transferred to someone else. And so it's not just about being healthy. It's not about exercising or eating well. All of those things matter. But on top of that, it also matters, you know, what lives in your gut, what have you been exposed to, and then what could be transferred. And so that's why even being healthy doesn't automatically make you a good donor.
Right. A perfect example of this is a recent donor who applied to our program. And on paper, they look great, right? Like no antibiotic history and regular bowel movements and all the things that check the list. But then when we went to do stool screening, we identified resistance to certain antibiotics, like bacteria that were resistant to antibiotic treatment, which for a patient who's, you know, immune compromised, that could be really a bad ending. And this is why we do the screening. But this person has no knowledge or would probably never in their lifetime have the problem of having an issue with that particular bacterial resistance. But in this context, from a donor perspective, they couldn't be accepted into the program as a result of that. So here's someone on paper and by all accounts extremely healthy, but who wouldn't meet the requirements of our donor program. And on the athlete front too, I mean, I think there's levels, right? There's like different levels, and the elite level, I would say, is not going to make an ideal donor. You know, the average consumer, if you will, would think, oh yeah, someone who's like an Olympian is probably going to be a perfect donor. Not to mention, you know, there's a lot of, in a lot of sports, there's a lot of use of performance enhancing things that are not healthy on the body. But someone who trains at that level is actually doing a lot of damage to their body, including their gut microbiome. And this is well established. And so that person who we would think, because they've achieved a certain level or status within a sport, you know, medals or whatever, we would think that they're going to be an ideal donor, but in all likelihood, they would not pass our requirements of being a donor. You know, some sports, for example, are really hard on the body, and they can get cuts or scrapes, and they can get infections and things that often require the use of antibiotics. And so someone in that context would be eliminated from being a donor because they have an overuse of antibiotics. And so there's going to be this spectrum, right, where someone's elite is probably not going to be a great donor, but then someone who's on the couch never exercising at all is definitely not going to be a great donor. So it's going to be somewhere in between, you know, trending towards, you know, more active, more fit, but not to the extremes. And so I think that's really the super donor narrative, is around the thinking that just because someone has achieved this high level of success in some area or sport means that they're going to be an amazing donor, but in all likelihood, they just may not qualify.
Yeah. And then, I mean, we've talked about this, I think, before, but people go, well, what if we get the purest donor, you know, that hasn't been exposed to anything? They would be the perfect donor. But that's not really the case, because there's a lot of other factors exposed to what we've been exposed to. But I'll let you take this, because I know you've talked about this topic.
Right. I mean, this comes up occasionally, right? And there's been some awesome documentaries, for example, on tribes, for example, in the Amazon jungle in Africa, that have just been untouched by human civilization. They don't have any of the chronic diseases that we in the Western world do. No cancer, no heart disease, diabetes, etc., which is phenomenal. I mean, that is so aspirational, and it's so cool to be able to study what's going on in their microbiomes that's potentially playing a role in allowing them to not have any of these chronic diseases. The trouble is, though, that if we as a Western civilization started to take on their microbiome, two things. One is probably most of those beneficial bacteria just wouldn't engraft, because they're being exposed to a totally different environment than us. They're eating very different foods. They're eating a wide variety of fibers that we're just not even getting. And so that's one problem. You might do a transplant, but not see long-term engraftment of these bacteria that have been otherwise lost in the Western society. And then the second part of it is that they have developed a relationship to microbes that would probably be considered pathogenic for us, particularly parasites, where they've created a relationship in their body, in their microbiome, where their immune system has a synergy with these parasites that is preventing the development of some of these chronic diseases. Maybe they're playing an anti-inflammatory role in the body, and there's a mutual benefit between the parasite and the human body. But if you were to give that to someone who's ill, which, the recipients of an FMT transplant are generally ill, right? If it's in the context of C. diff, they could be, days or weeks from dying just because of the progression of the illness. And so if you were to, and on top of that, they're generally older and they're generally vulnerable. They've usually come out of a hospital stay, again, in the context of C. diff. And other indications, not necessarily. But here we have an older person who's potentially immune compromised and is otherwise, depleted from an energetic standpoint. Their bodies are just weak. And so we are going to expose them to a bacteria or a parasite from someone who's extremely healthy in the context of someone within these tribes, has no environmental burden because they're just not exposed to all the toxins and chemicals that exist within our water and within our food and within our air. And so in most cases, it would probably kill them or do some significant damage to their gut that they just wouldn't otherwise be able to overcome. Personally, I love the idea of being able to go to one of these tribes, being a healthy, younger, fit person, being able to trial and seeing the impact of an FMT transplant from someone within that type of a community to see the impacts that it would have on my gut. But I would go in very armed, right? I'd go in with antibiotics and antiparasitics and a bunch of other things. I would also bank my microbiome before going in case it didn't work, so I could wipe my slate clean and go back to the microbiome that worked for me. But that would include a lot of risk, and that's a risk that personally I might be willing to take, or other lunatics who are curious about this sort of work. But the average person who's a recipient for FMT shouldn't be taking those risks. And going back to my earlier introduction, like, healthcare is about risk management and deciding, is this intervention going to be riskier for the patient than just not doing anything or doing another intervention? And of course, with all the informed consent, that's a critical part of it. But yeah, in this context, on paper, the theory is that would make a super donor, and it would be aspirational to think that kind of a person could be used in a donor program. But in reality, it would probably be harmful and have a lot of risk, making the benefit of choosing someone who would otherwise be called a super donor a very bad idea. And so that's where this concept in general of super donors is not a great one. I mean, it's well-intentioned, and that's great, but in reality, it's a bad idea.
All right. So there's two other parts that I think that go into this story. And the first one, I think, is that super donors have an overemphasis on the donor. And that's not the whole story when it comes to FMT. So there's a couple of things here. One of them is that the recipient, and we know this through research, the recipient matters. So how we can call this prep, but what happens before FMT is administered can affect how well the outcomes are. So it's not all on the donor. And I think this focus on donors, solely just on the donor, I think underplays that what you do with the recipient before they do FMT is really going to affect the outcomes. And this is something that, we really highlight based on the research, but also on our understanding of how the gut microbiome works and how engraftment and things work. But one of the steps here is prepping the gut from the recipient standpoint so that we're lowering the threshold it takes these new bacteria to engraft, right? So we want to kind of wipe the slate clean from a recipient standpoint so that when we put new bacteria in from a donor, that bacteria has a better chance of engrafting and making a healthier new kind of microbial environment. Do you want to add anything to that concept?
Yeah, I mean, that's the pre-treatment part, right? Prepping the microbiome to receive this transplant and allowing an environment within the gut where these new microbes can engraft and can become a part of the recipient's new microbiome. That's a critical part, but also the during and after part, right? Like, we know there's a lot of things that damage the gut microbiome. One classic example is alcohol. Like, we know alcohol is toxic to the microbiome and damages the microbiome. We know this through studies, and the studies on everything from like minor use to excessive use. And so the things that you can do from a lifestyle standpoint during and after the FMT transplant are going to play a significant role as to whether or not the microbiome that you've gotten is going to stick and stay around for a longer period of time. Of course, antibiotics are an obvious one, your diet, your sleep, your exercise levels. So there's a lot of factors before and after that are going to be as or more critical to the success of the transplant than purely picking the right donor. Again, it's a very, very important part, but there's many other factors that play into the long-term success of this treatment actually working out.
Perfect. And I think maybe that's the next thing we talk about, is just the idea of what you do before and after FMT so that people can get an understanding of it, because I think that's all part of this story. I mean, our last video, we talked about donor screening, manufacturing. Today, we're kind of getting a little bit further into donors, but then I think maybe that's the next step, is what's happening on the recipient side, because I think it's a complete picture when you're looking at FMT, that it's, you know, that initial donor screening and getting into the kind of nitty gritty and understanding everything about the donor and what the donor could transfer. And then you get into actually making the product. And on the other side, it's what's happening with the recipient, so that, you know, that donor and that product that we've, you know, screened and made sure is, you know, going to be as effective, has its best chance. So it's kind of a longer, more thorough process.
One analogy that I use that maybe we can inject here is that, and this was when I was actively working with patients and treating patients, is that we would, I would describe it like this. Look, our goal is to get to the top of the mountain. And what determines the incline, or how steep the climb is going to be and how likely you're going to get there, is determined on the amount of prep you've been able to do to your microbiome. So whether that be from an antibiotic standpoint, antifungal standpoint, or an herbal antimicrobial standpoint, a diet standpoint, all of these things that are done to do prep work are going to reduce the incline. And so it's going to be easier to get to the top of the mountain, which is FMT success, right? Engraftment, reduction of symptoms, improvement in whatever metric we're trying to measure. And so if you do nothing, you may still get to the top. There may be less, resistance from the microbiome that you have currently to accept this engraftment. And so that's wonderful. You may get there, but to increase your likelihood of getting to the top and achieving success, you want to increase your odds. And you can increase your odds by preparing your microbiome, by making sure that if there is, say, like fungal dysbiosis or an overgrowth of fungus, which we know, especially in the context of C. diff, prevents engraftment and long-term success of FMT in curing C. diff, then it's going to be important to eliminate that and try to reduce that. It's not about getting to zero, to the point of having no fungal overgrowth, because we always have fungus, and fungus overgrows in the context of not having a healthy microbiome to counter its overgrowth to begin with. So all of these things that you can do to prep the microbiome, and they're really individualized on the patient. We always, did a lot of screening of the patient to see, like, what is the medical background, what are their symptoms, what types of treatments have they done in the past, what's worked, what hasn't, and then testing as well to determine what's going on in the microbiome and what can we do to try to eliminate that. For example, some patients have a lot of Clostridium overgrowth. Well, there's indications there for using an antibiotic to reduce the Clostridial overgrowth and, again, allow for the microbiome to come in and have less sort of work, if you will, right? It's almost as if, like, the microbiome will come in and it can displace some of these microbes, but if there's too many of them, it may get overwhelmed and be unable to have a full effect that is lasting. And so that's the context. And I think something that you didn't mention, but is also important in this, is the protocol, the FMT treatment protocol. And this is something that we really enjoy working with when it comes to the prescribers or the doctors that are utilizing our products, is coming up with FMT treatment protocols that are going to be more likely to be successful. Like, if you were to just start, for example, with 1 or 2 capsules a day, it's probably not going to have a really enduring effect in a context of someone who's been chronically ill. It's going to take more than that. And we, for example, as a quick context, would suggest like a loading dose of using a lot of bacteria at once to start to kind of inundate this microbiome and erase or overcome or overpower their existing microbiome to create meaningful change right now, and then we would continue to support that over a longer period of time.
Yeah, and that's something I think we're seeing in a shift in kind of understanding the research and how clinical trial protocols are changing. We're seeing a change depending on what types of things are being kind of tackled in different clinical trials. How the protocols are evolving seems to be tied into both the level of dysbiosis and the length of that dysbiosis that's been happening, and how chronic or severe the issue that's being kind of looked at in these clinical trials. And that's one of the things that we spend a lot of time on, is trying to understand how the field is evolving. And that comes from, if you want to treat somebody for a very long time in a clinical trial, we don't want to do colonoscopies for months on end. And so we see that evolving in the field, changing the methods that are used to create these products and to treat patients, but as well how the protocols and lengths of treatments are changing, I think, as we see more. And that's one of the kind of crazy things about FMTs, the growth in clinical research in this area, because I think we're starting to peel back the layers to understand that the gut is playing a big role in a lot of parts of our body, and seems to be either, you know, at the beginning of a chronic condition, or is something happens during kind of that condition being kind of becoming chronic that that affects the gut. But there does seem to be changes in the gut microbiome with a plethora of conditions now. So that really does seem to play a role. And I think we're starting to understand kind of the balance between understanding what's happening in the recipient and then what's happening with the donor. And I think that's something for everyone to kind of understand, that this is more of a holistic approach. There's a lot of parts in it. You have to look at everything, and it's not similar to just giving a pill and walking away. There's more to it. And then I think this kind of ties in with, how do we best understand what makes a good donor, what role the donor plays? And I think in a wonderful world, we would fully understand how FMT works. We would understand all the mechanisms. We would understand which bacteria are the best. But we're not there. And it's such a complex thing. I think it'll be a while. I think on the other side, something that is happening and being worked on is donor recipient matching, understanding what role the donor plays, understanding what the recipient plays, what their profiles look like, and which ones are going to be a good match, like the dating profile for guts, you know, which gut goes with what gut and which ones will be happy together. That's something I think we're starting to work towards. Are we there? No. And so there's a lot coming, I think, to understand this. And one of the things that's suggested in the research, and I'd love to get your take on this, is that there's a theme within some of the areas, specifically within inflammatory bowel disease. And again, that's probably because it's one of the largest studied in clinical trials right now. But the idea is that if donors matter, should we use multiple donors at the same time? Now, from a GMP or a manufacturing procedure, we can't just take a bunch of donors and mash them together. But if you're doing a longer protocol, you could use multiple donors within that. So this is the idea, instead of pooling the donors all at once, using multiple donors over a treatment window. And while some research says that doesn't have any effect, some research says that there's better outcomes using multiple donors. I guess, what's your take on this idea of, because we don't have donor recipient matching figured out yet, and because we don't know which bacteria are the best in every condition, is it better to just kind of use multiple people with a variability of different types of makeup to try to solve that problem until we know the answer?
Yeah, I mean, I think what you're highlighting here is the future of medicine is really precision, being precise about deciding which interventions make the most sense for a given patient based on their profile. And that's everything from FMT, which is obviously what we're working on, but the same goes for medications, right? There's going to be a future where we understand their genomics, their microbiome profile, their whole medical history in a way where we're going to be able to know before even giving the intervention the likelihood of it being successful based on a whole bunch of data that's been learned on specific to a group of people, but then can be applied individually. So I really think that's the future of medicine in general. And that's something from an FMT context where we would like to play a role, is understanding how to be more precise about matching a donor to a patient. But in the interim, as you pointed out, I do think there is some utility to using more than one donor in the course of a treatment. Now, again, it comes down to the risk profile, right? Like, does using 2 donors make sense, but would using 10 donors over the course of a treatment introduce more risk that would be unnecessary? And I think that is the case. Like, more is not necessarily better. More to some point is better. The challenge as well is understanding adverse outcomes. Like, if you're using multiple donors, even after each other, there's overlap between treatment, and you might not be able to pinpoint which donor, if there was an adverse event, which thankfully in FMT, they're very, very rare. But if there was, it would be harder to pinpoint. And so I do think, yes, in the interim, when we don't really understand how to match a patient and a donor, I do think there is some utility of providing product from more than one donor, assuming a treatment that's done over a longer period of time. In the context of C. diff, it doesn't really matter. You can get away with one single donor. You can get away with 12 pills over 3 days. And that's going to create a really positive outcome for most people. But in the context of someone who's dealing with a chronic disease, or as you described, IBD, it may be beneficial if you're treating over a longer period of time, up to a year in some of the research, then absolutely, you may as well expose that person to a variety of different microbiomes in hopes that there's some overlap in the benefits that one might get as a part of that treatment. So yeah, I think there's definitely utility there, but I would caution against the idea of like more is better. And so let's use like 100 different donors over a period of time, because I think that would it would increase the risk profile, and that the likelihood of being beneficial is probably not that much better.
Yeah. And the other side of that is if anyone has 100 people that would pass donor screening, I would be extremely impressed, because there's just so few people. So I think donor screening plays a huge role, especially, not just in terms of what their profile looks like, but also safety. And so I think we've debunked the idea of super donors, or at least gave everybody something to think about if you believe in this concept that there's, one unicorn donor that exists. And I think,
or we've highlighted that to become a donor, you're automatically a super donor. Like, if you meet all the requirements that make our donors and other dual banks that exist donors, then I think you're automatically a super donor. But yeah, I really think it's, I think it's been a tale as old as time, right? Like, the discovery of some elixir that will allow us to live forever. I don't think it exists. I mean, being healthy is hard. It's harder to be healthy today than it ever has been in history, because it requires you to do a lot of things and say no to a lot of things and be a much more conscious consumer than if you were, 100 years ago when you grew all of your own food in most areas, right? And if you did get food, it was from your neighbor. And so I think nowadays it's much, much harder to be healthy. And so someone who has made the conscious decisions over their lifetime to be healthy, that's what it takes. And so this concept of like finding one person or one thing that's going to be the fountain of youth doesn't really exist. It's lots of things. And that's really what it comes down to from a donor screening standpoint. There's not one magical microbiome out there that's going to help everybody. But are there microbiomes out there that can help a lot of people? Definitely. But yeah, so I think we've either totally debunked this idea of a super donor, or really added fuel to the fire and letting people know that to become a donor, you're automatically a super donor.
All I'm hearing is all of our donors are unicorns. That's what I'm focusing on. But it's true, to do this, like, I could never be a donor, and I'm always impressed when people pass any part of our donor screening, because I think I make it like 3 questions before I'm out. And so it's not everybody could do it. And we are very lucky for the people who do, because they make such a huge impact. And so I think next time we should talk about kind of what goes into prepping and what goes into post FMT, so everybody can get an understanding a little bit about, we've talked about the donors, we've talked about manufacturing. Let's talk about the other side, what goes into the recipient. And if you loved everything we talked about, please take a look at our other videos, because there's so much information here and we only kind of touch on a little topic every time. And if this has sparked your interest in FMT, As someone who works in the medical field, we do have a new ebook, which I'll link in the description, so that you can take a look and kind of get an understanding of what FMT looks like and what this whole process looks like. And then you can tune in next time and see us talk about the other side. Let's prep. What does prepping a recipient look like? There we go. But thank you so much for watching. And Jason, thank you always for joining in and having a chat with me.
It was fun. Thank you.